And welcome to episode 9 of Straight from the Hip. I'm Benoy advanced practice physio from London, and with me, my friend and colleague, Callum, hip specialist, all the way from Perth. And we got an exciting episode on this session where we sort of finally we moved away from FA syndrome. So I think it's gone for more than 8 episodes, which is, I think, we went in more depth. But again, hip is just not about hip impingement. We're going to cover all other pathologies. So one of the most common pathologies which we see in clinical practice is hip OA. What if I told you that 1 in 2 physios may be missing a diagnosis of hip OA? Now, this is not a statistics from decades ago. This is actually from a paper which we'll discuss shortly from Heber et al., where 2023, where only 50% of physios were able to pick up a case of hip OA. And that's really important because, in my opinion, I'm sure Callum will agree, the earlier we pick up these cases, the better the prognosis and also the management. Traditionally, the view is of a 60 or 70-year-old patient waiting for a hip replacement. Here, we're talking about a 35-year-old young active male who's been told his pain is muscular, or a 42-year-old female recreational runner whose hip symptoms has been written off as being just a bit stiff and weak glutes. So we see this a lot where active middle-aged adults are quietly losing capacity, reducing their activity levels, and slowly drifting towards inactivity. And as clinician, I think this is something I see quite a bit. So the problem with hip OA is it doesn't really announce itself as a dramatic entrance. It slowly creeps in, fluctuating symptoms, load intolerance, and the slow erosion of confidence. And so this is why I thought although it's a very common topic, we feel it's generally under-recognized, especially people in the 30s and 40s and early 50s, and also in active population. So quite an exciting episode. So Callum, how have you been, and what can viewers look for on this episode?
Yeah, I think you've summarized that really nicely, Benoy. Now, you've referenced a paper that you and I were just talking about, and I think it might be worth us leaving this reference, maybe if we can do that, onto the podcast.
In the show notes, yeah.
Because this was a study that was conducted in 2023, and admittedly, it was only done in Australia and New Zealand. But I kind of think if it's happening in these countries, surely it's got to be happening in other parts of the world as well, like the UK. But yeah, that was the stat. They found that 1 in 2 physiotherapists were not confident in diagnosing hip osteoarthritis. It was probably part of a small hypothesis, but they didn't arrive at that conclusion. And we now know that just like knee osteoarthritis is a clinical diagnosis, we don't necessarily need the imaging to support that. So it's quite a concerning study, I thought. And I think we're going to dive into that on why a physiotherapist is struggling to diagnose hip osteoarthritis, or at least hypothesize it in their clinical practice. So what we'll look at is what early hip OA actually looks like clinically. And as you said, Benoit, this isn't a massive bombshell that drops in and all of a sudden, bang, someone has got hip OA. It is something that progresses over time symptomatically. Why it's frequently missed, and what the limitations of relying completely on imaging are, what those clinical signs, symptoms, looking at pattern recognition, and as you said, why is it important for us to identify this diagnosis early? Because it can certainly influence management and patient outcomes. That's everything that we'll be diving.
Yeah. And I think it might be useful to spend a bit of time, just a few minutes, on the paper, because I was having a read, and this is my few thoughts on the paper. Obviously, the readers, I advise them to look on there properly. And the two, three things which stood out was, one was, which was quite surprising, was about 86% of the participants didn't change their outlook even after objective. So there's a bit of a cognitive bias. So I think a big cognitive bias among therapists is hip OA generally happens as you get older, in your 50s and 60s, you're limping around or having a walking stick, and you can't still be doing sports. So I think the profile, so we see is that hip OA, traditionally, if you look at the guidelines, it's the nice guidelines, it's more than 45. But we see that it's not strictly, nothing magical happens at 45. Obviously, you still, there's an aging process, but these things can happen much earlier, especially if you have some morphology like a large cam or dysplasia, or young childhood hip disease like Perthes. So I think the perception that hip OA is more an elderly patient's disease, that's an issue. Plus, also knowing that it can be quite vague, and most of the times early symptoms are more like stiffness and more like low tolerance, intolerance issues. So What's your thoughts on, obviously we're not bashing anyone here, and because we know it's sort of difficult here, but it's sort of trying to break that myths and preconceptions against hip OA.
Yeah, and I think you summarised that nicely. I think we look at guidelines, and you've referenced the NICE guidelines there, and say that age 45. I emphasise this to everyone. NICE guidelines are just that; they are guidelines. They're not absolutely bulletproof, and it's anything like post-operative guidelines. They are just there as a guideline. I've now got to adjust my thinking because I said to you, Benoy, just off camera, that the youngest person I've seen now with a total hip replacement is, well, age 29 when she actually had it. She's come to me at age 30. And that was because of hip dysplasia advanced so much that it was significant hip osteoarthritis, had to have the hip replaced. So that does not fall into the guidelines at all. And sure, that was maybe a hip dysplasia misdiagnosis. But as you said, with osteoarthritis, symptoms are typically very, very vague. And that's what we're sort of going to break down and go into. For me, why does it matter clinically? I think it's because historically, hip osteoarthritis has always been spoke about as being a wear and tear condition. But what we now know from all of the research is that it is a very, very complex whole system issue, whether we're talking about cartilage and labral tissue, if we're talking about bone, synovium, muscle function, but we've also got to think about the human system in
Yeah,
psychological factors. How does that influence pain processing and perception? How does that influence behavior? So we're
yeah,
talking more structure, we're talking more about radiology. And
yeah,
radiology was something you wanted to talk a little bit about, but I don't know if this is your entry point here. But how often would you see that? Because I get it here, I suppose, with our healthcare system in Australia, that people come in with scans already. It's
yeah,
happening all the time. They come in with an X-ray or an MRI, and it shows a level of osteoarthritis at some point along that continuum, but
yeah,
that doesn't always correlate with their pain, their function, what they can or cannot do. Is that a
yeah,
conversation you're having a lot
yeah,
with
yeah,
demographic?
yeah. I think that's a good point on imaging. So I think there are a couple of stats I use with patients. So the main thing is here when we talked about in the previous episodes like hip impingement, we don't say something like symptomatic FA. We say FA syndrome, which is for people who have symptoms. So whereas the hip is different. So right from the beginning, I want to make two distinction. One is radiological hip osteoarthritis, so something you see on an MRI, and second is what we're talking here is symptomatic hip OA. So they're two different things because there's one large, as I think this is from the Framingham American study where they looked at more than 1,000 people after the age of 60 who had they picked up patients sort of who had the problem was about nearly about more than 50-60% had some lipoa changes, but only 1 in 5 people who had the radiological symptoms had symptoms. So we need to be very clear on radiological signs where symptoms, and I'm sure Callum will go through the symptoms separately. So very common as you get older, just like with rotator cuff degenerative repairs, meniscal tears and other things, you're going to see the increase. And that's why the NICE guidelines use the cutoff as 45. But we have to, as a clinician, we need to make that very clear. Is that relevant? Is that OA changes? And the problem with imaging is, for example, like the MRI is very good at picking up even like pre-OA on the X-ray. For example, we can even pick up the chondral changes, which some people will say as early OA, as early as 30s and 40s, because the
Yeah.
resolution is very high. So, but there might not be any symptoms at all. So that they might be coming you to your clinic. Let's say you got a 38-year-old male, very active, comes with standard adductor-related groin pain. Maybe he went straight for an MRI, which I would say might not be a good idea, but many people do that because sometimes clinical examination or even ultrasound is enough, but people jump for an MRI. And the MRI shows obviously adductor tendon, but it also shows quite a bit of OA of the hip joint. But in fact, the patient doesn't have any symptoms of hip OA. It's pure adductor-related groin pain. But the patient is highly concerned here because it's showing some sclerosis, some subchondral cyst, some labral tears, which is not really relevant here. So I think we have to be quite careful with imaging here because imaging will pick up with age. But here, the whole episode premise is on symptomatic hip OA, not radiological. What would you say on that?
Yeah, no, completely agree. We've had a case even this week, Benoy, of a 70-year-old, a woman
Yeah,
with ultrasound GTPS bursitis and hip
yeah,
OA.
yeah,
No hip OA symptoms, which we'll go into in a little bit on what that actually
uh,
looks like. So we have to take these radiological reports sometimes with a bit of a pinch of salt. And to be honest, in this particular consultation, the patient didn't actually bring up the hip osteoarthritic related changes that saw on the scan. That didn't seem to concern her. She did not bring
Yeah.
it up. So neither did I. It was just
Yeah.
not necessary. All of the symptoms linked to lateral hip pain, GTPS, that was the concern. So that's what we spent the time talking about. We didn't even circle back to the hip.
Yeah.
It wasn't at the forefront of her brain. But you're right in that some people, it really is at the forefront and it can be very, very concerning for them. So I think you've put that very nicely in that we have got radiological features of OA and then we've got symptomatic OA, and having that
Yeah.
distinction very, very important. My opinion, and tell me if you agree with this or not, Benoit, but I feel that patients only really, for the majority of the time, only get meaningful education, meaningful input once their hip OA has radiologically progressed very significantly, or if their symptoms have progressed very significantly, or if there is a discussion around surgery.
Yeah.
And, be the 40, 50, 60-year-old person. So I feel like some of these things happen a little bit too late. And I'm wondering, is that because the diagnosis wasn't correct? Is it because they didn't present with symptoms or enough of what, I suppose society and physiotherapy would deem enough of a set of symptoms to warrant intervention? I'm not too sure, but that's just probably
Yeah.
my observation
Yeah.
from clinic.
Yeah. I think I'd agree. This is where I think the difference between the neo is a bit different. So because the early symptoms, which I'm sure we'll go through in a second, are not really very severe to warrant investigation. They're more like a bit of age-related changes, deconditioning, muscle stiffness, and it can be quite non-specific. And that could be one of the reason, for example, in that study where people missed that.
Yeah.
So, it's not somebody with a knee pain, they come with like a localized pain and swelling and they're limping. Most of the early signs are more like rotational. They have difficulty with the range of motion. They have difficulty with some sort of extension activities and those sort of things which you'll go through. So it's definitely a tricky. And I think this is sometimes a bit of a debate here is, for example, if you look at pathologies like hip dysplasia and some of those large cam, we push for early imaging. I'm on two minds on whether you got somebody like a 45-year-old who has some signs of OA. I'm not too sure whether getting an X-ray or imaging really is necessary because most of the guidelines says that if it's clinically presents as OA, we don't really need imaging. But some patients will not accept that. They'll always say that we need imaging. But I think in some cases, most cases, I would say with the OA, imaging is not really necessary because you know the clinical findings. Would you agree with that?
Yeah, definitely. And we know, just like with knee OA, is that same with the hip, these are clinical diagnoses. That the research has
Yeah.
said that the imaging's great and everything for looking at the anatomy, but is it going to confirm a diagnosis? Not necessarily. Is it going to change the management that we're going to be doing? Yeah, probably not
No.
necessarily. I suppose
Yeah.
sometimes we could talk about this again, Benoit, in a bit more detail, but when I'm referring for imaging, it's more to escalate because
Yes.
symptoms are not improving, symptoms are worsening. Am I concerned about red flags? Am I concerned that there's something else going on that's not MSK related? I mean, that's when I'm thinking imaging, or if we've tried everything and symptoms aren't improving, because that happens, and then we're talking about surgical planning.
Yeah.
But those are the things we're talking about trying to get further imaging. But no, I
Yeah.
would agree. We do
Yeah.
not need X-ray to confirm our clinical hypothesis.
Yeah,
Yeah.
and for some people who are like in private practice or advanced or in a triage role like an FCP, so this is sort of something when do teaching with my colleagues with my junior staff is for me like there are 3-4 instances where I go for imaging in OA. One, as you said, correctly pointed out, is when it's not responding, it's getting not it's not following, lots of flare up, getting worse. So that's definitely one we want to make sure that we're not missing anything sinister. Number two is when you are referring for surgical opinion, where you've done your bit, and the patient thinks you feel they're having night pain, the walking distance is getting reduced. Number two, number three, which might be more relevant for UK physios, is you're going to refer for injection. So you think maybe this patient needs an injection, and we'll have a separate episode on looking into different type of injection. You're looking for a procedure, so you're referring for a procedure. So one, not responding, getting worse. Number two, referring for surgical opinion. Number three, as a pre-injection tool, like a screening tool to help into, because I think most sensible clinician will not inject unless you have a baseline imaging. You want to know what exactly you're injecting into exploit your joint. So those
Yeah.
possibly are three scenarios where you might want to imaging, but otherwise it's going to be purely decided by your clinical presentation. So I think that fits in
Mhm.
nicely into the next section is we've sort of covered the imaging. How does early hip way actually look like clinically?
Yeah, you touched on this at the very start of the episode, Benoit. Don't expect someone with hip OA to say it was sudden. It was a snapshot. It was a day. It was a moment. This isn't like an ACL tear or a tendon or a muscle rupture. It's nothing like that where there's an incident or a very clear mechanism. It's normally something that progresses intermittently over time, and it's quite load related as well. So I often find that patients will start to say that, oh, I normally like to go for a 1 or a 2 hour walk every day, but I've been finding recently I'm struggling to do that. Um, that's just one example. Another would be I've been struggling to get in and out of the car a little bit more recently, or I've been struggling to walk up and down stairs. So there's normally a very simple activities of daily living function at play where they've started to know. And I would most often, approximately 70% of the time, I'd say, but I'll round it to the nearest 10, 70% of the time, most of the pain is around the anterior hip and groin region.
Yeah.
But at the same time, it can also refer to the lateral hip. It can also refer to the buttock. And often as well, I've seen patients come to me saying that they've been diagnosed with knee pain or that, I don't know, a GP or a prior colleague has said that they've got anterior knee pain, but it's actually being referred from their hip. So when there's hip joint pathology, particularly OA, it can refer down the anterior thigh towards the knee. So it can masquerade as knee symptoms. It can also refer to the back as well. So it's very, very diffuse. Um,
Yeah.
a bit like I'd compare it to a tendon. We quite know that with tendinopathies, it's quite localized. Even with
Yes.
GT, like greater trochanter, it's generally quite localized. But yeah, with hip OA, it's very diffuse and it can map anywhere from the hip, groin, buttock, thigh region. But as I say, 70% of the time, they will report it as being at the anterior fit into the groin, sometimes even towards the genital region. And that's where their symptoms sit. They often say to me stiffness or an achiness, quite somatic in their pain presentation. So a stiffness feeling would be if they've been sat for a long car journey. That's really common here in Perth
Mm.
because Dublin is so massive. You're in a car for a long time to get anywhere. And a lot of people drive south, and that's a 2, 3, 4 hour drive. And they'll say after doing that, they get out of the car, their hip groin is very, very stiff. Morning stiffness is a key hallmark one. And I would say anywhere from 5 to 45 minutes it might take for that stiffness on rising to eventually ease up. I've sort of mentioned longer walks, stair ambulation, pivoting, getting in and out of the car. That's probably quite a big one. Um,
Yes.
those are sort of some examples in terms of function. Other ones that I find as well is pain with putting on socks and shoes or
Yes.
trousers or leggings. And I want to be very
Yeah.
specific with this one because I think this is important when you ask the question. I've had some people say, no, they don't get that. And it's because I've asked the question wrong. So we're not
Mm.
talking about someone flexing their spine to bend forward to put on their socks. That probably wouldn't do it. You need to be very specific and say, if you're sat upright and you bring your knee towards your chest to put your socks on your feet, does that bring on your pain? That's what we mean
Yes.
by putting shoes and socks. So it's not a spinal movement. It's flexing internally or externally rotating the hip, however they do it, for those tasks. Crossing legs, for guys, it could be a Faber type pose, outside of the ankle on top of the knee, or it could be crossing one leg directly over the other. Squatting, rotational movements, pivoting, longer walks, things like that. These are, I suppose, anecdotally, my cluster of signs, symptoms, functional tasks where the hip OA presentation tends to come on. Have you got any other ones, Benoit? Anything that
Yeah,
you?
yeah, yeah. I think the big one is what I find with this patient is the pain is not like screaming out, and it's not like debilitating in the initial stages. It's more like a nuisance discomfort. So, for example, like as you said, the stiffness, the prolonged sitting, shoes and socks, and they struggle with rotational activities. For example, getting out of bed, getting out of car, or
Yeah,
they've always been to a yoga class, they're struggling, or they feel, for example, somebody who's still running. This is a group I see a lot. So let's say if you got a 44-year-old female with early OA, the main thing she will complain of is there's more like the stiffness and that sort of discomfort for a few days after the running. So they've
mm,
done a long run, for example, on a Sunday. It takes them 2-3 days to really feel back to normal. It's not like they're limping around, but it feels uncomfortable for a few days. So you slowly creeps in. That's the way to think it. It's more a very gradual, a stiffness, a loss of range, and also recovery is a big problem as well. They can't really be doing a lot of intense classes back to back. They feel they need to recover, and most people will dismiss this as part of middle age decline sort of thing, because they'll think, okay, which is true in one way, but here it's much more localized. So I think it's more subtle, and you have to probe it, see what exactly, and the pain is not very stark and, very sharp. For example, like hip impingement, it's on your face. It's like they say they can't sit for 15 minutes. They having the sharp catching pain. So it's not like that. It's a bit more subtle, unless they're in a flare up, which is a different, presentation. But most people, when they come in, they'll come with a little bit of back pain, bit rougher to the knee. So it's a bit of a mixed picture. So that's why I think we need to really go into the objective side. So
Mm.
this is where I think let's jump in. So obviously we've talked in our previous episode about the examination here, but what are some of the key things which you look for in an objective evaluation of somebody you already think of possibly early hip OA?
Yeah, I'm gonna throw a miniature curveball your way, Benoit, as you see a lot
Yeah,
of runners,
yeah, yeah,
because something you've mentioned there with runners, and I
yeah,
see a few runners, but I'm not going to say I see mountains and mountains of them like I know you do. But you've
yeah.
mentioned that someone will go for a run, and then the day after, 2 days later, they start to feel symptoms. Now, some of our listeners will start to think, hold on, tendinopathy presents that way as well. Quite a
Yes,
latent, delayed response, stiff, sometimes a bit diffuse. Like,
yes.
so how do we differentiate between those two? I think that would be an important one to touch on.
Definitely. I think, yeah. I think with that, for example, the most common tendinopathy I see with runners is GTPS and proximal hamstring. I think it's fair to
Yeah,
say those are the two most common. So, whereas with tendinopathy, it tends to be a bit more localized. So, we find it's more lateral hip, and with proximal, it's with sitting. So, the location of symptoms are quite useful. And
yeah,
also, if we're going to have a separate talk on GTPS. So, crossing legs, lying on the side with proximal hamstring is sitting.
yeah,
So, but to be honest, I've seen some OA where it coexists with the. So this is where we love hips. Is
yeah,
it's not as simple as OA and GTPS. So it's very common in a lot of women in middle age who are active to have a little bit of OA process in the background plus GTPS, but they'll come to you because of GTPS, but they'll have that background pain. And I find anecdotally, I don't have any evidence to back this up. I find once I sort of clear up the tendinopathy, the hip OA symptoms behave well and they sort of subside down. So they feed on each other. I think the
yeah,
biggest, trouble, and I mean, the challenge I would say people have with hip, which I would say, I'm sure you'll agree with this, is to know what's the primary driver. What's really driving this? Is it the GTPS? Is it the hip OA or that? So I think that where sometimes you need a couple of sessions to pick
yeah,
this up. So obviously keep that diagnosis open and things can coexist. One of my theories is when you lose that range of motion with the hip OA, then your tendon starts getting overloaded, because if you're losing that extension, if you're losing the internal rotation, the tendons have to work harder because there is not enough range to dissipate the forces. So it's not unusual that when you start with OA, eventually you end up with a lot of tendinopathy as well. So
yeah,
it's not like a simple boxes as well. So definitely keep that diagnosis open. But yeah, so let's go to
yeah.
the objective findings. Callum, what sort of things will you be looking for in your examination?
Yeah, I think you've already touched on it there, and the biggest one was internal rotation.
Yeah.
And I'm just going to link this a little bit back to our FAI discussion. Do you remember, Benoit, we were speaking about the difference between men and women with FAI, and we spoke
Yes.
about the
Yeah.
differences with hip morphology between the two. So, again, I don't have any evidence to back this, what I'm about to say. This is anecdotal. But if I compare a male to a female with hip OA, suspected hip OA, with the male, I find that they've got significantly reduced internal rotation, but they've also got significant reduction in their flexion range of movement, and
Yes.
flexion really brings that on. With women that I've seen, they do have a lacking in internal and or external rotation, but their flexion doesn't seem to be affected as much. And
Yeah.
I would encourage people to go back to our podcast and listen to where Benoit spoke about, and I spoke about the differences between male versus female hip morphology. But rotation's the big one, as you said there, Benoit. So if someone's losing their internal rotation or external rotation range of movement and extension, the tendons, like the gluteal tendons, like the hammy tendons, if we're talking athletes, runners, endurance people, they then start to get overloaded. And that's where it's very common to find OA coexisting alongside a tendinopathic issue. So with OA, I'm looking for a loss of passive range of movement. And when I'm testing for rotation, I prefer getting people prone, just because if I'll have a look at them supine. I don't know if you do this, Benoit, but I'll get them laying
Yeah.
supine and go through your internal, external. If I want to get, I suppose, a more accurate reading, if I'm measuring it, I'll get them laying prone. Tends to relax the
Yeah.
body a little bit better, tends to relax the hips a little bit better, and we're probably getting a better indication of a full rotational profile. So if I see a loss of rotational profile, that's a big one for me. We've spoken again with FAI. If we do a Fadir, a Faber, Fitzgerald, Scour test, whatever all of those are very sensitive to capsular restriction patterns. Not specific to anything in particular, but they're very sensitive to where there is capsular restrictions. So those type of tests can also be useful. But again, have to bear in mind that if we're talking GTPS, if you do DEER or a Faber, that can also annoy someone with gluteal tendinopathy or GTPS. So that's where the pain location that you touched on, Benoy, becomes very important. Are they talking they've got lateral hip pain that's vocal or intercostal going down the sides of the leg? Or are they feeling it with that deep sign, that deep point or triangulation sign where it's going into the groin, anterior hip? That'd be sort of big differentiators. Reduce extension during gaits and also with incline walking. Sometimes get them on the treadmill and doing incline walk, or we'll get them to do some steppers, something like that. Something that's pushing their hip into extension, you normally find there is a loss in their stride length because that's them trying to guard and protect their hip, which again, that can lead to tendon overload. Their walking speed also reduces. So if you're testing someone's gait, don't just look at how they're moving. Get them to walk slowly, then ask them, can they walk up quickly? And sometimes you might find as soon as you add velocity to their gait, that can then also bring on their symptoms when they try to protect the hip. Yeah,
Yeah.
they'll be at once,
Yeah.
I would say.
Yeah, definitely. I think sometimes we have to be mindful that there is overlap between those massive overlap between FAA symptoms and hip OA. But there are a couple of points which I would say, which obviously we can't really say with full certainty, but I find the irritability is much more higher in FA syndrome. So we
Yep.
find we are more sensitive with, like we talked about sitting. So most patients with hip impingement can't really sit for 3 hours continuously, but they will struggle. Whereas OA patients will struggle when they get up. So they've been on a long drive on the car for 2 hours, 3 hours. When they get out, they will limp a little bit. So that's classical hip OA. They've been inactive for a while. They've been sitting for a while. And one more thing, which is, I don't know whether this is even published, but I find it very useful clinically, is people with OA, especially early OA, respond very, very well with anti-inflammatory drugs for, because they already have that process established. Whereas
Mm.
with FA syndrome is a bit of a hit and miss. So I find with early OA, they take a bit of brufen, they take a bit of naproxen, they're so much better. And maybe that's one of the reasons they also get delayed, because at the early stages, they can manage very well with few painkillers here and there. So I think a good response to anti-inflammatory, again, raises the suspicion that it could be early OA, but in the latest stage, it might not respond, because the latest stage, they get night pain as well. So I think, and we have to be also be aware, they might have a phase where they're transitioning into AA. So let's say somebody with an impingement, a morphology, and maybe from the age of 40 to 45, they're not here, they're not there, they're not FA, they're not OA, they're solely, it's not like suddenly they wake up on the 1st of June and become OA. And before that, they were FA syndrome. It doesn't happen in one day. So I would say the process might even take 3, 5, or even 10 years, where they
Mm.
slowly are going into the transition. And if you find people in that transition, it can be quite tricky, because I find that late 30s, early 40s are a bit tricky, because you can't put them in a clay box. Would you say that is something you find?
I agree. And I suppose with the physios I speak to, they're very frustrated because there's one thing that we love doing as physios, and it's finding the problem and then giving a solution to the problem. And yeah, when you've got someone in that mid to, I'll say 35 to 40 years old, and it doesn't fit the guidelines, it doesn't fit what typically is published in the research. There's something I do want to highlight, which I was meant to highlight earlier on, which helps me a lot in the subjective history because, as you and I talk a lot about, the objective stuff's great, but the subjective is where it all sits. I want people to take from this podcast, so they go away with anything, stop thinking that someone is too young to have hip OA. That's the big one
Yes.
for me. You're not too young to have hip OA. We need to remove that myth. Something that I asked to pretty much everyone that I see was there any childhood hip issues? So you and I have spoken about FAI in our previous podcast, Benoit. So do we know that there is a diagnosis of FAI there? Do we know there is a diagnosis of hip dysplasia there? Because we know that accelerates the chances of hip OA related changes. When I get younger people in, I ask, did they remember going to the GP for hip, thigh, groin related problems? Because if someone's got a history of Perthes or a Cephi type injury at the hip, that's also going to accelerate the chances. Was there previous trauma, fracture, previous
Yes.
surgeries? Because if any of that's happened, then the chances of them having OA increases from a younger age. We know that
Definitely.
radiologically, athletic people, so if you meet someone that very sporty as a kid, went into academy soccer or academy anything, or competing at a high level through their teens and 20s, we know radiological signs of OA are more likely to be present. Again, whether that correlates with symptoms is a bit hit and miss. But the other one I want to touch on as well, because we've had some of this in clinic recently, there is more research coming out that anyone that's had a history of eating disorders, now whether that's overweight, someone that's been overweight, so if we go down that end of the spectrum, there's an increased chance that on the load bearing joints like the hip, there is an increased chance that they could have early onset OA. But there's also at the other end of the spectrum as well. So if someone's had anorexia, bulimia, you need to think about nourishing your bones, nourishing your labrum and your cartilage, nourishing your tendons, your muscles as well. So it could be on any end of the spectrum. But if there is a history of that type of thing, then again, that can accelerate the chances of someone having symptomatic hip OA. And I want to throw that in just to help deepen people's subjective, I suppose, assessment and their clinical reasoning to dive a little bit deeper.
Yeah, that's so all great point. Yeah, definitely great points. And I think that's where I think the depth comes in. This is where that really reminded me of two more things, which I'm
Mm,
glad it came now. Is first thing is, this is a patient I saw like 8 months ago. 58-year-old female, active female, history of dance background, very active, and she has this clinically, she has exactly hip OA symptoms, that stiffness, that all the struggling thing. But she's been missed by a couple of therapists, and it also baffled me because I checked the range of motion on the hip, and she had like something like 60 degrees of internal rotation and about 50 degrees of external rotation. And then when I looked at the X-ray, she had significant OA, and this is what I discussed with a few consultants later. It seems a significant subset of people with hip dysplasia who don't lose the range of motion. Sometimes they have ridiculous range of motion, but they have all the symptoms. So sometimes the range of
mm,
motion, internal rotation is not really useful. That's why the subjective, you always go back to the subjective. So that stiffness.
yeah,
So that possibly is one reason why she was missed, because she has amazing range of motion despite her age. Because we know people with hypermobility, anti-ovation, and dysplasia have very good range of motion despite OA. So that's one point. So the
yeah,
second point is, which is quite interesting, this is a longitudinal study which looked at people with chronic GTPs are at high risk of getting OA. And one reason for that is because the loading pattern changes. If you're limping, if your hip abductor is weak, you have more loading in the frontal plane, and eventually you need to OA as well. So things overlap. So again, there's
yeah,
two little points here is range of motion is very useful, but it might not be true for everyone,
yeah,
especially people with hypermobility, dysplasia, and antiversion. Number two,
yeah,
people with GTPs are at a higher risk of OA, which is why we need to manage GTPs very well, because we don't want them to develop OA as well. So things,
yeah,
that's what, hips are complicated because they overlap and with time as well. So a couple of few points there to add to the mix there. But again, that's what makes it the whole conversation more relevant to clinical practice, because we know that people don't just fit in boxes and say,
yeah,
my internal rotation is limited and it's going to be a bit more different. But I think that comes to a last point here, which, because we're going to go into management in the next episode, is, how does some will argue, how does really early identification change management? Why is it important? Why don't we just call it as non-specific hip pain, rather than jumping in, finding rather than finding hip OA? I'm sure there'll be critics here saying, are we labeling them too early and just making them more fearful? What would be your answer to that argument?
yeah. I think the context to that question is really important, because I absolutely agree that if we put a label onto someone, that
Mm.
can introduce more fear, can't it? I think you
Yeah.
need to read. My impression of this is you need to read the room. Benoy, you're a clinician, an advanced practice clinician. So if you were coming to see me and you were in the patient hot seat, and I was the clinician looking after you, you might feel really strongly that you want a diagnosis. You want a label because you're a physiotherapist. Labels mean something to you, and it's important for clarity for you. So if that's helpful, we could have that discussion and go, okay, look, Benoy, because of X, Y, and Z, it's very, very likely here that we're presenting with symptoms that correlate with hip osteoarthritis. And if you go, right, great, that's what I needed to know. Now, what does that mean for me? Then we can have that conversation. There are other people that have been conditions think that osteoarthritis is degeneration, it's about wear and tear, it's eventually meaning they're going to need to have a toe replacement, all that thing. So read the room. Sometimes, Benoit, I don't even say hip osteoarthritis. I might just say,
Okay.
look, I think we've got a grumpy hip. I think we've got an
Yeah.
irritable hip, and that could be
Yes.
it. What do you mean by that? And we'll just say, okay, well, look, we know that nothing neurological or vascular or anything medically sinister is going on here. We're not convinced you've fractured anything, not convinced you've torn a muscle or anything like that. I would say, look, you've done a massive hike, these past 2 weekends, and your hip hasn't liked it. Your hip's just a little bit grumpy at the moment. So we just need to get things to settle down. And that could be it.
Yeah.
In our heads, you and I, Benoit, might sit in an MDT meeting and say, okay, this person's got hip osteoarthritis. But if I'm reading someone in front of me and I think putting that label on them is not going to be helpful to them, I'll just use words like a grumpy hip, a slightly irritated hip, and then reassure them. And that's
Yeah.
the importance that comes in there. We want to reassure them, encourage them to stay active, to keep moving, understand what their goals are. Like, do they want to keep hiking? Do they want to keep running? Talk to them about all that we can help them get there. The biggest thing in musculoskeletal practice, I can't remember the year of this, within the last 5 years. I remember reading a study, and it was about musculoskeletal pain and practice. But one of the biggest prognostic factors to MSK pain is self-efficacy.
Yes.
So
Yeah.
if we can help people to increase their self-efficacy about themselves, that can be one of the biggest predictive or prognostic factors of any musculoskeletal complaint. And sometimes I use you as the example, Benoit. Maybe having the hip osteoarthritic label there could be very helpful for Benoit. That will help your self-efficacy. But if I've got 70-year-old Doris that comes to me and I just don't feel it's appropriate to give that label, then we don't give it. We use
Yeah.
different terminology, we use different language, still highlight the hip isn't a problem, but we use very soft language where the idea is to settle concerns, empower, motivate, encourage, to help drive and increase their self-efficacy. So
Yeah.
for me,
So
that's
I
what
think
I
that's
think.
a great, yeah, yeah. I think you a great point out, you've covered all some great points here. And I think important is always the setting you're in, because, if you're an FCP practice, if you're seen for the first time, or somebody like me and Callum, we see sometimes patients who had symptoms for 2 years, 3 years. When they come in, we can't just say you got a grumpy hips. They won't be too happy with us. So it depends
Yes.
when they come for a specialist like us, they want some clarity. That's why they come to us, because they want to know. I've seen a lot of physios, it's not improved in 3 years. And I can't just use very vague labels there, because they're looking
Yeah.
for certainty and also planning as well. So, but early stage, I totally agree with you. We don't have to jump to labeling at all. We can just say it's a bit irritated, it's a bit grumbly. Let's settle it down. And most patients will accept that. It's only when things don't improve or it's
Mm.
affecting their quality of life, people really want some. And I would say, which we're going to discuss in the second episode, which was quite surprising, is most general public don't have problem with osteoarthritis. It's things like wear and tear and things like that, which we'll discuss separate.
Mm.
People understand osteoarthritis is part of normal human phenomena as you get older, and it's not like a shock, like something like the labral tears or something drastic. So osteoarthritis is not an alarming diagnosis if expressed well and also empathetic and also using the right language, which will go in. So let's try to finish off with some key take home message, which for me, which I've picked up from your talk here. Number one, we agree that based on the studies that we are missing hip OA, especially in that sort of late 30s, 40s, and early 50s, young active adults, and we don't have to the typical idea is it's a 60, 70 plus. So we need to pick up this patient much earlier. For me, early diagnosis means better input and also better prognosis. And the second point is early hip OA doesn't behave like with a lot of irritability, like a structural disease. It behaves more like a load intolerance. Most patients don't have constant, severe, disabling pain. It comes like an intermittent, active related discomfort, especially after inactivity, some morning stiffness, reduced tolerance to walking. So some good and bad days, a bit of flare up. So it's quite subtle. And obviously, we have symptoms like putting shoes and socks, crossing legs. So having a targeted approach is useful. And a very useful objective test is your reduced deep interrotation, especially checking them in all planes, looking them in supine, prone. And some patients will not have restriction, especially some females with dysplasia will not lose their range of motion with OA, but most of them, especially men, will lose their interrotation. So, but important point, reduced interrotation doesn't mean OA on its own. It's just one part of the diagnosis. And imaging can be useful, but we don't want to jump into it too early. So if you feel like, you have a straightforward case, I won't really rush into imaging unless I'm looking into surgical referral, or maybe they're not improved. Most of the cases, X-ray is not necessary, and it's just one part of the story. And early recognition doesn't mean that we're going to rush them to the surgeon. It means that we're going to jump in and have a comprehensive rehab, which we're going to discuss. And exercise will be a key intervention. So early recognition is very useful from better outcomes. It's not over medicalization. In my opinion, it's good clinical practice. It's sort of picking up much earlier so that the patients do better. So again, it's a great opportunity to build resilience, get not waiting for things to deteriorate. We don't want to wait till it's so bad that we can't really do much. So pick this up early, and then we can do a good job, because much easier when things are at the early phase. So any final thoughts there, Callum?
And my final thoughts on that is your job as clinicians is to diagnose as early as we can, but help to reduce fear, encourage people to stay active long term, support self management strategies, and also to help build self efficacy. I think that's our
Yeah.
role here.
Yeah. Yeah. So that's great. We'll be back with more honest, clinically grounded conversations. In the meantime, come and find us at Function to Fitness, and Callum is at Hip Rehab Lab on all our social media platforms. Drop us a message. Let us what you think. And if you want to take your learning further, we have a lot of resources. So we recently published an FAA booklet. So the links are there on our social media. We also have live courses. All our details, check it out. And until next time, keep listening to your patients, and let's go straight from the hip.